We're going to go ahead and get started. So hi, everyone. Good afternoon. Welcome to the ASTHO desk side media briefing. My name is Stephanie Rhodes. I'm the Director of Media and Public Relations at ASTHO. Just quick Zoom etiquette. I think we're all very comfortable with Zoom at this point in the pandemic, but just make sure you're muted. I will unmute reporters when it's time to ask a question. And then we're going to use the raise your hand feature during the Q&A portion. So I'm going to hand it over to Marcus Plescia. He's our Chief Medical Officer, and he's going to introduce our experts and panelists this afternoon.
Great. Thanks very much, Stephanie. And hello, everybody, and welcome on my behalf to today's media call with the Association of State and Territorial Health Officials. We really appreciate you joining us. As Stephanie mentioned, I'm Marcus Plescia. I'm the Chief Medical Officer for the association. And so today we're going to talk about the fact that, as all of you know, as of November 2nd, the Pfizer vaccine was approved for children aged 5 to 11. We believe the pediatric vaccine will provide an important opportunity to protect our children from severe disease, keep our kids in school, and bring the pandemic under control. States have been getting ready for this, and many have already started vaccinating. In addition, changes to vaccine formulation and packaging will help us roll out this new vaccine. But we also know that public preferences of where they get the vaccine may be different this time around. Today, we have 4 speakers from 4 states to provide you more detail and context about this. And I'll introduce them in the order that they will appear. First off will be Dr. Nirav Shah, who is the president of ASTHO and who's the director of the Maine Centers for Disease Control and Prevention. Next up will be Dr. Ann Zink, who is the ASTHO president-elect and is the chief medical officer for the state of Alaska. Third will be Dr. Jose Romero, the secretary of the Arkansas Department of Health. And fourth will be Dr. LaQuandra Nesbitt, who is the director of the District of Columbia Department of Health. So with that, I will turn it over to Dr. Nirav Shah, who will make initial comments.
Thank you, Marcus, and good afternoon, good morning, everyone. We very much appreciate all of you joining us today to discuss with us where things stand with respect to COVID, and in particular, the arrival of childhood vaccines, and on top of that, boosters. Across the country, as we speak right now, including in my own state here in Maine, children between the ages of 5 to 11 are being vaccinated against COVID-19. On top of that, residents who have for several weeks now been eligible for boosters are receiving them. Just in my own state, we've seen a 94% increase in vaccination rates over the past 2 weeks. That means not just in Maine, but across the country, we go into pediatric vaccination against COVID-19 with the wind squarely at our backs. Right now, there are at least 2 challenges that are front and center for state health departments around the country. The first is an operational one. From an operations perspective, the authorization of Pfizer's vaccine for children aged 5 to 11 creates challenges, but of course, opportunities. Public health is preparedness, and states are ready and have been ready to take the vaccine and turn it into vaccinations. Now, of course, again, this comes with challenges. Getting a vaccine to a new group of providers in new locations for a new group of patients and their parents is, well, new. But the thing is, state health departments can do several hard things at once. We've demonstrated that throughout the pandemic. The addition of the pediatric vaccine on top of boosters is a welcome one, and states are ready for it. The second challenge that I'd like to spend a bit more time focusing on today is around communications. The conversation with pediatric vaccines is in many fundamental ways different from the conversation around adult vaccines. Up until now, adults were making decisions for themselves. But now, with the addition of pediatric vaccines, parents are effectively making decisions, sometimes in concert, sometimes unilaterally, for their younger children. In effect, this introduces a separate second audience to the conversation. and parents have concerns. What I want to focus on today is something that we are seeing with respect to the ways in which those concerns are often being addressed. The bottom line is that oftentimes those concerns are not being addressed through correct, accurate, well-done science, but rather through misinformation. The bottom line is that we are facing an epidemic of misinformation around pediatric COVID-19 vaccines that will complicate the rollout of these vaccines across the country. The misinformation that we are seeing at the state level now is in many ways qualitatively different from what we've seen before. It's louder, it's more prevalent, and it spreads much more quickly. In effect, the misinformation around pediatric COVID-19 vaccines is like the Delta variant itself. It travels much more quickly, it's much more damaging, and most fundamentally, it threatens to undermine the progress that we've made to date. These lies have consequences, and it's kind of like what Mark Twain noted, a lie can spread halfway around the globe before the truth even has a chance to get its shoes on. The misinformation we're seeing complicates our efforts at every turn. Well-intentioned parents who would have otherwise vaccinated their children may delay or decline vaccines outright, motivated in part or in whole by misinformation that they see oftentimes online. The misinformation also shifts the conversation away from answering honest, earnest questions about the benefits and potential risks of the vaccine to having to correct bad faith nonsense. Misinformation creates a world where people don't know what to believe, so they believe nothing. And we've seen what can happen in prior outbreaks of infectious diseases when misinformation is widespread. For example, misinformation spread amongst the Somali American community in Minneapolis many years ago in the midst of a measles outbreak greatly depressed the rates of vaccine uptake in that community, having consequences. Now, the last 20 months have been confusing enough. And this type of misinformation elevates the confusion that many parents have and can often put them in a state of decision paralysis. Ultimately, this type of misinformation could undermine the faith in public health at a time where it's needed more than ever. What we are starting to see, and what we are hoping to overcome, is a wait and see attitude on the part of many parents. In the midst of a surge of the Delta variant, a wait and see approach to vaccinating children elevates the risk. And that risk extends beyond just the childhood risk. It extends to the broader community, family members, schools, who may themselves be at elevated risk. Now, addressing misinformation is not easy, and we acknowledge that. But it can be done, and it happens one conversation at a time. Indeed, those conversations are the cornerstone of good public health practice. It is, in effect, what state health departments do all day long. State health leaders are on the forefront of those discussions, but the greater volume, more strident tone, and pervasiveness make this style of misinformation harder to contend with. In effect, state health officials are like the Red Queen from Through the Looking Glass. We have to run just as fast as we can, but just to stay in the same place. Now, the stakes here are very high. Vaccinating children will be critical for their health, the safety of their schools, and the safety of things like holiday gatherings. It will take all of our collective efforts to stay one step ahead of the avalanche of misinformation that we are just now beginning to see. So with that, Marcus, I will turn things back over to you. Sorry, Marcus, you're muted.
Sorry about that. Thanks, Dr. Shah. Next up, we have Dr. Ann Zink.
Thanks, Dr. Shah. Thanks, Marcus. It's great to be here with many of you. I come to you today both as the Alaska State Health Officer, but more importantly, as a mom. I remember the very first time that my kids got vaccinated, and it was honestly terrifying. I was in medical school. I had been studying science and medicine, But the thought of having my little one, who was perfect in every way, getting a shot was awful in many ways. And I understand and relate to the anxiety that can come with having to make a decision about your child, particularly in all of the politics and policy. And as Dr. Shah just talked about, misinformation and honestly disinformation in this space. And so as a parent, I would encourage every other parent in America to talk to their pediatrician and to look for trusted sources about this decision about getting your child vaccinated, because it's a really important decision. And thinking about the reasons to get your child vaccinated, I wanted to go through 5 separate reasons in thinking about the COVID-19 vaccine that I think about as a parent, as well as a state health official, and thinking about vaccinating, and why, honestly, I'm ecstatic that we have this vaccine available and accessible, and am thrilled that my children are vaccinated and are able to be protected. The first is because they are incredibly safe and efficacious. Millions of vaccines have been given across the state, across the country, and billions across the world. While the PEDS vaccine is new, the science is not new, the data is not new, and it has been an extension of the information that we already have. It is a smaller dosage, really to take into account children's unique and very strong immune systems. Our kids are designed to make strong, robust immune responses to infections, and that's why they only need a small amount of vaccine to create a great response. And so this is specifically designed for kids and for their unique immune systems. Nothing is perfect and nothing is risk-free, but honestly, vaccines are the safest thing we do in medicine. They are safer than most over-the-counter medications, and we do things for our children every single day, like putting them in a car seat, knowing it's not perfect, but knowing that it is our best tool to protect our children. And looking at the risks of COVID-19 and the safety and efficacy of vaccines, this is our best way to protect our children with the ongoing threat of COVID. Number 2 is because it can make a difference in our children's lives. It reduces the chance that they'll become ill or sick. As a parent, when your child gets a fever and feels miserable, you will do anything to make them feel better. And this can help prevent them get sick. It helps to prevent them having the risk of long COVID. We see that children are at risk for this, and even healthy children can become hospitalized and quite ill from COVID. While they tend to be less impacted than adults, it is not perfect, and less impact does not mean no impact. Number 3, it helps to protect those around them. It's clear now that children can efficiently transmit COVID-19, and there may be others in your family or your community who are at risk, including those less than 5 who cannot yet be vaccinated, elders, those who are immunocompromised. And again, the data has become clear. Children can transmit COVID-19, and the more people that have immunity in your household, the less transmission of COVID-19 there is. And so our kids are a part of our herd. They're a part of our family. They're a part of our community, and protecting them helps to also protect the larger community, which helps to support them as well. Our children need caregivers and siblings and grandparents and their loved ones, and helps to be a part of that. Number 4, it saves you time and money. These vaccines are free. They're widely available. It's been fantastic that we have so much at the initial rollout. It was a wonderful day yesterday in Alaska, seeing so many families and kids getting vaccinated across the state. As one friend said, I cried tears of joy. My kid didn't even notice that they got vaccinated. It was a real day of joy yesterday for us in the state of Alaska. But time off from being sick can be costly for you, for your job, from them out of daycare, the cost of hospital expenses and care. So even from an economic perspective, this keeps you working, the kids healthy, and us all moving forward. And number 5, vaccines are our best defense. Viruses are hard to treat. Viruses are best treated by our immune systems taking down the virus. And when our immune systems are taught by vaccine how to take them down, we do better. We use vaccines constantly through all sorts of diseases and viruses. We have vaccines that have protect over 400 million illnesses and have prevented almost 1 million deaths from children between 1994 and 2018. We have a lot of data, science, and information about the importance of vaccines in children to support children, their health, and our community's well-being. And for those reasons, we're ecstatic to have these vaccines widely available, accessible, and free for you as a parent to make that choice to vaccinate your child. And with that, I'll hand it back to Marcus.
Great. Thank you very much, Dr. Zink. Next up, we have Dr. Jose Romero. And I'll just mention, some of you may know that in addition to being the health officer in Arkansas, Jose Romero is the previous chair of the ACIP. So take it away, Dr. Romero.
Thank you, Dr. Plescia. Thank you all for allowing me to participate and to be here today. As a practicing pediatrician and as a someone who still sees patients as an infectious disease expert. One of the reasons why many pediatricians went into this subspecialty was because we realized that early on, if we make an intervention, if we care for a child, if we prevent a disease, we can establish a long and healthy lifespan for that individual. That for me is one of the major reasons why I entered pediatrics. The fact that we could immunize against a disease, prolong their life, limit the sequelae of infection is a major contribution to the healthcare of children and adults in general. COVID is not a benign disease in children. To date, there have been nearly 2 million cases of COVID disease in children. There have been 8,300 hospitalizations. There have been 2,316 cases of multi-system inflammatory syndrome of children and 94 deaths. We now have a vaccine that has been shown to be effective and safe for the prevention of these complications. In addition to this, there are other complications that parents need to consider. There is the complication of having myocarditis, that is inflammation of or around the heart, which can have significant consequences for the life, so longevity, for the activity, and for that child. We know that these vaccines are safe, that the rare cases of myocarditis that are associated with the vaccine are self-limiting and resolved by themselves. We also know that in adults, and we are beginning to get more and more information on this in children, that there are long-term complications of COVID. That is the long COVID or long haul COVID, as some call it. We know that in adults, this can be significant. And one study in the UK suggests that 7 to 8% of all children have symptoms that persist many, many months after the infection. And these impact on the child's ability to learn in school, to participate in activities that allow them to interact socially, and generally make the experience of being a child much, much less meaningful in the long run. Again, these vaccines have been well studied in older age groups, and are now available for children. I, as a grandparent, am strongly recommending this for my grandchildren. I would not do so. When I sat on the ACIP, one of the things that I always mentioned was that when my time came to get the vaccine, I would get it, and I would advocate for its use among my family members because I think it is appropriate. The other issue that these vaccines help us now address is the issue of disparity. We know that that ethnic and racial minority groups, so American Indians, Alaskan Natives, African Americans, Latinos, children in the age of 5 to 11 make up about 1/3 of the cases of COVID that we see. We also know that they make up about 1/3 of the cases of multi-system inflammatory syndrome in children. So in vaccinating these children, we protect them. It is important to know that for our state, we have begun to roll these out. We have approximately 85% of our VFC, vaccines for children providers, signed up to administer the vaccine. There are literally waiting lines now for parents to accept this vaccine and have it for their children. So this is a major step forward in having a preventable disease, and we need to make sure that parents understand the significance of it. Dr. Zink has addressed this issue. Dr. Shah has spoken to the misinformation that is out there. We, as physicians and public health officials, need to get the message out that this is a safe and effective vaccine for a significant disease. I'll stop there and turn it back to Dr. Plescia. Thank you.
Great, thank you very much, Dr. Romero. And now we will turn it over to Dr. LaQuandra Nesbitt, our Public Health Officer in the District of Columbia.
Thank you so much, Marcus, and it's great to be here with you all today and to talk a little bit about what we're expecting in the District of Columbia. Again, thank you to ASTHO and for all of you for allowing me to be a part of today's conversation, which is indeed a critical one to have. Here in the District of Columbia, we are indeed excited for yet another monumental moment in our country's response to COVID-19, where we have the opportunity to have an impact on a huge part of our population being eligible for vaccination. I think it's no secret that the District of Columbia is a relatively young population, and 5 to 11-year-olds account for about 7 to 8% of our population overall. So we have the opportunity to be able to provide a degree of protection from the impacts of COVID-19 for yet another group here in DC who now we have learned not only have their parents been anticipating the approval of the vaccine, but the children themselves have been anticipating the approval of the vaccine for their age group. We all know that the COVID-19 vaccine is our best chance of ending this pandemic and moving on to the next phase of what normal will be for us here in DC. And similar to the other phases of our vaccine rollout in the District of Columbia, we will be experiencing the benefit of doctors' offices, pharmacies, and other community locations like community rec centers and community settings and schools having access to the COVID-19 vaccine for 5 to 11-year-olds. We're also going to be able to, this time around, more immediately host a series of pop-up locations around the city, including in school settings, beginning this Friday, that will be in close walking distance and easily accessible to the vast majority of our families here in DC. The process for ordering vaccines, as many of you know, has changed or evolved a lot since we began ordering vaccines back in December of 2020. And we're grateful for that and the partnerships that we've had with our partners in the federal government. So this time around, many of our healthcare providers were able to have vaccine available immediately after the CDC's director made the decision to approve vaccine for use in this population. And our providers were able to begin offering vaccine to those families who desire to have their child vaccinated as early as yesterday with great enthusiasm to our families. One of the questions my team and I have received here often is how are we planning to distribute vaccine equitably across our city? About 3 out of every 10 children in this age group live in some of our most under-resourced communities here in DC. And so we're asked often, how are we going to focus on residents of color and residents who are living in lower income areas? Early in our vaccine distribution efforts, we were receiving a very limited supply of vaccine. And in order for us to ensure that there was an equitable distribution of that vaccine, we implemented, like many jurisdictions, a registration process. But our registration process focused on allowing residents who lived in zip codes that had the highest disease burden for COVID-19, the opportunity to have early and priority access to the majority of the vaccine appointments and supply that we were receiving. And we did this as long as demand for the vaccine exceeded supply. With the release of vaccinations for 5 to 11-year-olds, we no longer have the need to continue to use that type of process, that same rigorous sort of registration and appointment process, because the vaccine supply now is expected to meet, or even in some instances, it may exceed demand in the initial days or weeks. As such, we're more immediately able, as I mentioned before, as early as this Friday, to offer walk-up opportunities for people throughout the city to get vaccine, including in our communities of color and our communities where the majority of our children and families live. So our ability to have this type of structured program that provides walk-up opportunities for families to get their children vaccinated during the day. We're also hosting them in early afternoons and evenings immediately after school and on the weekends will better accommodate the schedules and needs of families and create equitable access to vaccines for all those who wish to be vaccinated. But what we've observed in DC, and this is an observation of other urban settings as well, is that our vaccination rates have in fact been lower for Black and Latinx adults aged 20 to 44 when we compare them to their white peers. And we've also seen the same trend for youth 12 to 15 years old when we compare Black youth to white youth. And we may see the same observation in the 5 to 11-year-old population. And we make this hypothesis because unvaccinated parents may be less likely to have their children vaccinated. And this, of course, causes us some concern. So even with the design of a program that equitably distributes vaccine, we still have to have people choose to get vaccinated and have information that they trust. We need people to want to listen to facts about vaccine and vaccine safety and efficacy, not be swayed by myths when they are making decisions about how to get vaccinated and when to get vaccinated. So that's going to be critically important for us. And we have very clear evidence that shows that when our Black and Latinx residents get vaccinated, we can eliminate disparities in COVID-19 outcomes. When we look at our data for 65 years and older, Black and Latinx residents 65 years and older have gotten vaccinated at the same rates as their white peers. And we've essentially eliminated the gap in COVID-19 outcomes, the racial and ethnic gap in COVID-19 outcomes in that age group. And so we know we can do the same if we can increase vaccine coverage in those populations. So we're really excited about the opportunity to continue some of our grassroots efforts as we have our community COVID Corps that continues to work and to do outreach to our communities of color, our low-income neighborhoods, to provide them information about vaccine safety and efficacy, to mobilize our youth corps, and to get the benefit of some of our vaccine requirements that are in place for our youth who are playing sports in our school systems. All of those things we hope will in fact continue to have better outcomes and vaccine coverage, leading to better COVID-19 outcomes for us overall. Thank you.
Great, thank you very much. Hopefully you've gotten some good overview now, not just of how we're rolling out the vaccine across different states, but also how we're handling things like vaccine hesitancy, misinformation, and equity in how the vaccine is actually distributed. We're going to open it up for questions now, and we're going to use the hand raise option on Zoom. So if you just raise your hand on Zoom, then we will call on you in the order that you put your questions in. If you have a question that's for a specific one of our speakers, if you want to mention that, we'll refer the question to them. Otherwise, I'll try to make a decision about who's the best to lead off. And just on the off chance that you're not familiar with Zoom, if you just pull up your pointer down to the bottom of your screen where it says reactions, if you click on that, that's where you get the option to raise your hand. So we'll go ahead and start taking your questions now, Stephanie.
Seeing any hand raises just yet, but don't be shy. Here. Will go ahead.
Yeah, let me see if I can roll things off. I'll ask a question.
Well, actually,
you got
sorry,
somebody?
Marcus. I think, yeah, Will Stone from
Okay.
NPR was saying that he couldn't find the hand raise button. So if you can't find it, just put your question in the comments and I'll unmute you. And
okay, great. Thank you. So I'm just curious. I know a lot of parents are struggling with this issue of if their kid was possibly infected, before the vaccination, they don't know if they want to do it or exposed even. So how are you working with that issue with parents?
Dr. Romero, you want to lead off with that one?
Yeah, thank you. So, we know that some of the individuals that actually were enrolled in the trials had been previously infected because they had titers, but those titers are very low. So what I try to do and what I'm trying to do publicly is inform parents that, yes, the child may have had an infection in the past, but that infection, that quote, natural, end quote, infection, doesn't confer the same degree of immunity as vaccination does. We don't know how long that immunity will last, and we don't know how high the titers are. So for those children, we think that it is very important that they continue to go through the immunization process so that their titers will boost, because there will be a boost if they have been infected, and we'll protect them. We're not encouraging parents to seek any of the antibody tests that are available. This is a decision that needs to be made without that. And again, our recommendation, my recommendation at this time is that if your child has had COVID in the past, that once they're over the COVID, then they should receive the full immunizing series for that age group.
And if I may add a couple additional items, we, in some of the regions in Alaska, we do a lot of testing, and we see kiddos who test positive 2 or 3 times with reinfection. So we know that one previous infection does not prevent you from getting reinfected. And we know from adult data that immunization after previous infection provides more protection than just that previous infection alone. And so it's for those reasons, and continue to encourage parents to get vaccinated, even if their child had had it. The last thing I would add is that as a clinician, I see a lot of kiddos who come in and their family thinks that they had COVID, because COVID can look like a lot of other things. It can look like RSV, it can look like influenza, it can look like adenovirus. And so just because your kid had a cough or a fever or runny nose, they may not have had COVID. So don't make the assumption that they had it as well. And so for both of those 2 reasons, families who previously either had COVID or thought they had COVID still encourage to consider vaccination in this age group. Thanks.
A number on that. Dr. Zink referenced this, but there's, and Will, you may be aware, last weekend or last Friday, US CDC published an MMWR quantifying the benefits of vaccine-induced immunity versus virally induced immunity. This was in adults, not children, but nevertheless, the findings are instructive. And they found a 5-fold difference in the likelihood of being affected with COVID if you were sort of virally induced versus having vaccine immunity on board.
Stephanie, I think we can take the next question.
Oh, going to be from Carla Johnson at the Associated Press.
Hey, thanks for taking my question. The holidays are coming up, and I'm curious, for those of you who will have everyone in your families vaccinated, what kind of other precautions you might be taking around having a big family meal together with multiple households. Is having everyone in the family vaccinated enough to have no masks when you sit around the table? Thanks.
Dr. Nesbitt, you want to lead off with that one?
Sure, thanks, Marcus. And thank you, Carla, for the question. We get a lot of people who want to know from us what they should do for the holidays. And we just finished Halloween, and we gave people clear guidance around Halloween, and we'll do the same for the winter holidays. Last holidays, the last Thanksgiving and the Christmas and holidays were very challenging for us in the US. And we learned a lot in terms of the impact of small family gatherings and travel, domestic travel on COVID-19 transmission in the US. And we saw cases go down after those holiday seasons. And we did not have vaccines. And so we do have vaccines now. We do know that it is okay for families to get together when people are fully vaccinated. Things are a little bit different when you are mixing the vaccination status of individuals, and there are some additional layering strategies that we would recommend. And you need to take into consideration the health of the people who are going to be mixing. We always recommend that you take additional precautions if there are people who are at higher risk, especially if they're unvaccinated or immunocompromised, who are going to be part of that large family gathering. So you need to be thoughtful about if you're going to have family members there who may be immunocompromised, who have multiple health conditions, again, especially if they're unvaccinated, about the additional precautions that you may take. So increasing ventilation is always a good idea, having the windows open, making sure that you keep people separated as much as possible, thinking about ways that you're serving the food, and things of that nature are always a good idea. But I will emphasize that our social and emotional health is important. It's important just as our physical health is important. And our need to get together and to be with family needs to be a focal point as we think about going into this holiday season and having the opportunity to spend time with our families as well.
Excellent answer. Anybody want to add anything else to that?
Just add two little points. I thought it was a perfect answer, and I really appreciate Dr. Nesbitt highlighting that social and emotional need that we have, particularly because this has been so long and so hard at this point. I would just say, I think of gatherings kind of like road trips. You can do things to prepare for it. So you may want to consider changing your behavior beforehand, minimizing your exposure, and adding things like testing prior to travel, after travel, and making sure that we don't gather when people are ill, even if you're having a little bit of runny nose or congestion, because we are seeing a lot of RSV, we're starting to see influenza. And so this is a time of year to make sure that we aren't getting together if we're ill, and adding that additional layer. Thanks.
Stephanie, do you have anybody else?
Carla, your hand is still raised. I'm not sure if you had a follow-up question or not.
Well, I'll ask a quick question to maybe help keep us going. You know, prior to the COVID pandemic, you know, really the norm for where most people got their vaccinations was at their doctor's office. And things have really changed since the pandemic, partly because of the packaging and the distribution of the early vaccines. It was difficult to get it into doctors' offices. Also, it was very efficient to do things like big community vaccination clinics. But I think several of you spoken to the fact in your comments that as we roll out the pediatric vaccine, we think that a lot of parents may want to go to their doctor's office to get advice and talk to somebody. Maybe a couple of you could talk about how that's going. And I mean, we have a strong working relationship with our pediatricians and family physicians in our state, but you know, how's that going on the ground, and what are you thinking about as far as making that as effective as possible?
So
I can start really. Oh, go ahead, Jose. Please,
no, please, Dr. Shaw.
Okay, I'll be brief. You know, you're right, Marcus. Having as many channels for vaccination available as possible is critical. And we've been working with pediatricians and family doctors and nurse practitioners in Maine to stock them up for the vaccine. We've seen greater uptake with the pediatric vaccine at the doctor's office than we did with the adult vaccine. I think there are two reasons for that. It's easier to store. It doesn't require ultra cold storage. And number two, it can be ordered in smaller shipment sizes. It doesn't need to be 1,170 doses at a time. It can be down to 100. That's a benefit. The critical piece for us, though, is that for many parents who are on the fence, going to the doctor's office, studies suggest, is the only place they will go. And so by not having that option available, we're neglecting a large swath of the population that has the questions that Dr. Zink, Dr. Romero, and Dr. Nesbitt noted. If we relied solely upon the large scale sites, those will likely only speak to and attract parents who are already in to begin with. So that's why we feel like the doctor's office is particularly critical.
So,
you know, I'd like.
Oh, no.
So I'd like to add another, I had the opportunity to spend time at a federally qualified health center yesterday. And one of the things that we've noticed throughout the pandemic is our need to just think about reimagining the delivery of healthcare overall. And we've seen the increased use of telehealth services, both telephone only and also the use of audio-visual telehealth services. We know that some people have questions and they're going to want to talk to their healthcare provider before making a decision to be vaccinated. And so there is a scenario that we know will happen where you may have a telehealth visit, which may be by phone or maybe over Zoom or some other mechanism, where you get to speak with your healthcare provider and get all of your questions answered in terms of the COVID vaccine for your child, and you still may go to one of the community settings for the vaccine. And so we're asking our healthcare providers to really think about what their role is, the doctor's office role. Even if you choose not to provide the vaccine in your doctor's office, because you don't think you're going to have enough patients, et cetera, we still want you to take on the role of knowing about the vaccine, for talking to your patients about the vaccine, for encouraging your patients to get the vaccine, and making sure you know where in your community the vaccine actually exists. You may be the only person that the moms ever talk to about getting the vaccine. So it's going to be a very critical role that you can play in encouraging everyone in your private practice to get the COVID vaccine, even if you're not going to be the one to give it to them yourself.
So two quick comments on to follow those. So in a state like mine, where in some counties, the only place to get vaccination is the local health unit, that is the extension of the health department. You know, we are, from a public health point of view, trying to educate through our messages into the public, both linguistically and culturally appropriate messages for them, and trying to convince parents that way. But clearly, the VFC provider, the pediatrician is a trusted source. The other aspect, I think, which Dr. Nesbitt also touched on, is that we pediatricians, family practitioners, internists should never lose an opportunity to encourage vaccination. So in my practice, where I see children with specific infectious diseases, I still ask whether the parents are vaccinated. And I talk about why they need to be vaccinated. And I take the opportunity to educate if they're concerned. And I've had cases where if I take the extra time, the extra 15 minutes to talk to the parent as to why they're hesitant for the vaccine, I can change their opinion about that. So every contact, whether it's directly with a child or with an adult, offers an opportunity to get the vaccine into that family.
And I guess I'll add just a few other things. I appreciate this conversation. We've been spending a lot of time, all of us, thinking about how to get it out. What does this look like from an equity standpoint? Where and who? You know, just like Dr. Romero, you know, for us, 93% of our normal vaccine providers are currently COVID providers as well. And I think that just really speaks to their confidence in the vaccine, their excitement to be able to get it out. As Dr. Nesbitt just talked about, we are having to reimagine how healthcare is delivered, particularly immunizations. We did do the Alaska State Chamber did an incentive program to encourage people to get vaccinated this past month, including scholarships for younger kids and adults. And what we consistently saw is that when teenage kids got vaccinated, their whole family got vaccinated as well. It was oftentimes a family decision. And so it's been great to see a lot of pediatricians and others start to offer adult vaccine or boosters in combination with the kid vaccine as the family is making that decision. I think we also just need to keep in mind how busy working families are these days, how hard it is to take off time, how many different challenges they've had in being able to access care. And so making it simple and easy, we saw a lot greater demand, honestly, than we expected at some larger vaccine clinics yesterday outside of the pediatrician office, places like school districts that just offered pop-up clinics yesterday with long lines waiting to get vaccinated as parents who are ready. But then parents who are more hesitant or really want that conversation, having that conversation with their provider overall. So I think multiple different channels need to continue to be utilized and continue to move those forward. And I think we just need to expect intermittent surges. And what we saw previously with the 12 to 11-year-old vaccine is there was a little bit of a surge, but then it was just a steady increase of vaccination as families became more comfortable with it, made the time and effort. And I would expect the same for this 5 to 11, that we will just have a steady increase of families making that decision to get vaccinated after initial surge. And we want to make sure that it is available and it's ready whenever they are ready to get vaccinated, and make sure that they have the answers to really important questions as they are thinking about this decision about vaccinating their child moving forward.
Great, thank you very much. So last call for questions, and you know, if you're having trouble with the hand raising, just come off mute and say your question. Okay, looks like maybe there aren't any more, so we'll go ahead and close out then. I'd like to thank our 4 panelists for joining us in this session. I think you did such a great job with your opening comments that it anticipated all the questions that the media had. So I'd like to thank all of the media who came out. We've been working with many of you extensively in the pandemic so far, and we really look forward to continuing with those relationships. I hope you've liked our new format using Zoom. It gives you a chance to see us and us see some of you, and hopefully we'll be able to continue that in the future. I will close out by saying that childhood vaccinations are very, very important in our society, and we've been focusing on the COVID vaccine, but certainly when parents come in for the COVID vaccine, it's a good time to check whether their kids are up to date on all the other vaccines and maybe even get a influenza vaccine. So with that, I did want to say, if you have any additional questions or requests that you weren't able to bring to us now, you can send them to us at our email address, which is media@astho.org. Otherwise, thank you very much.